Next up, we have a pretty fabulous long-term relationship with our good friends at Central City Concern, and there is always a lot of good work going on over there. And in particular, we have some right now that's focusing on the high-risk space, which is a pretty big piece of real estate for where we all deal with, and how that can be impacted with different innovative little projects that look at the discharge space. So please give a warm welcome to Carlo De Gregorio. Carlo, come on up, my friend. And it's all you, my friend.
Thanks.
Thank you.
Okay, so hi. So about a year ago, I started at Central City at Old Town Clinic, and they were working on a project there using pre-manage. The health assistant that was there at the time would go through all of the ED visits for our team, admits, compile a list, together with the care team manager and the provider that was doing the high-risk huddle at that time. They'd come up with a list of people that they wanted to huddle on, come up with a plan. A lot of that was based on what their history was at the clinic, their level of engagement, their risk factors, how much they use the ED. And so that was the way it started. The goal was to reduce the hospital readmissions, the ED visits. The problem with this was, I mean, you're talking about our population at the Old Town Clinic, some of you are familiar with, but a week is a long time. And by the time you would get to it, they were already out of the hospital's hands. And then trying to outreach them, many people who don't have a place to live, don't have consistent phone numbers, trying to reach them was, problematic. So when I got to it, I was asked to come on and help out because the health assistant there at the time was going on maternity leave. And the project was kind of a little bit in transition. They were looking at it to see, like, what can we do better, because it's not necessarily turning out the way we want it to. And one of the things that I had noticed right away was the admits, if I could get in contact with a nurse manager, get in contact with someone right away while someone had their hands on them, we could schedule the follow-ups, start coming up with a plan, exchange information, get you all med lists, get med lists from the hospital, have an MTM in place before they even discharged. This was turning out to be a little bit better. We were seeing people actually follow up in the clinic afterwards. So initially it started with a provider, a nurse practitioner, our care team manager, a pharmacist, the nursing director would be in sometimes, the health assistant, which is what I do, which is mainly the grunt work. It's like pulling the records, checking in, following up, and the CareOregon CHIPS worker, the health resiliency specialist. Now we've tried to be a little bit more responsive, a little more streamlined. It's just the provider who is actually now a psychiatric nurse practitioner, our care team manager, our CHIPS worker, and myself. Sometimes we have someone from A&D in the clinic come on, but we found that generally if we come up with a plan, we can just touch base with them about a warm handoff and just give them a heads up and say, hey, we think this person could use some help here, and would you be available for a warm handoff? What it looks like now is it's a day-to-day thing. I compile a list. I get an email alert from pre-manage when we have someone on our team admitted. I still have to run the census to catch mental health stuff, because a lot of those go to Unity or other providers, and they're not going in as admits, so they don't get caught. And so those I have to check in and say, okay, are they receiving care somewhere else for mental health? Are they receiving care through OTRC where they have case management? Then I don't worry about that. But otherwise, whether they have a mental health provider or not, we start to look at them and say, is there something we can do to start to get them to where they need to be? The research goes into basically going to pulling records from Epic. So I'm looking at what Providence is doing when it's Providence or OHSU. I'm looking at what their case managers are writing, what their providers are writing, and getting that information for our provider once we huddle at the end of the week. And then with all of that, plus with our history there in the clinic, we're able to kind of come up with a plan, coordinate with the case managers. I start calling right away as soon as I see them admitted, just to say, hey, I'm here. If anybody's ever knows me, I'm pretty obnoxious sometimes because I'll just keep calling until I get a hold of somebody. And you have to. And so, as soon as I get a hold of somebody, it's like, do you need a med list? Do you have a plan? This is what we've got. Most of the work is done by the hospital, by the case managers at the hospital. I love RN case managers and social workers. You guys, if you have any doubts of whether the patient is one of ours, just call the clinic and ask. Yeah. So, moving on. So in the short term, the high-risk huddle, we're looking at what are the immediate needs after discharge. Is the plan to discharge them directly back into the community? Do they have a place to go? Is it a SNF, assisted living? Do they need home health? RCP is great. They are actually going to be expanding. When the East Side Clinic opens up, they're going to have a bunch of beds over there. It's actually going to be much larger over there. One of the hospitalists from OHSU is actually trying to start IV management at RCP, which would be great. Like I said, it's a matter. We're trying to be as responsive and just kind of like, is it working? Yes, no. Is it not working? Yes, no. And kind of figure it out as we go. Do they need a follow-up with PCP, with a mental health practitioner? Depending on the case, we ourselves might just right off the bat initiate a referral over to OTRC, Summit, for our really highly medically complicated patients. We try to get them on Summit when we can. And our CareOregon CHIPS worker, I don't know if you guys know Felicia, she is remarkable. And having her on the team is great because she's able to get some outside stuff that as a clinic we don't have. She can facilitate a lot of that. It's, I don't even remember, actually. Yeah, so she's a health resiliency specialist. I think CHIPS might have been an old acronym. Yeah. Long term, we're looking at what are the primary drivers that got them there in the first place. SUDS, homelessness, mental health, addictions, lack of housing. For a lot of our patients, it's yes. And so, how do we come up with a plan to mitigate these factors? What can we offer them? What are they willing to buy into? Where do they fit into the system? Which I think someone else kind of was talking about earlier. Is how do we figure that out? A lot of this is identifying barriers. And once we identify those barriers, how do we reduce those barriers? Some of the things we've learned from this, having a psychiatric nurse practitioner as opposed to a nurse practitioner come in. A lot of the patients that we see admitted are medical needs. And while they may be complicated, the medical outreach is pretty straightforward. Get them a follow-up with PCP. Some of them get a referral to Summit. A lot of them might just go directly to SNF, and then it's just kind of touching base with the SNF. Is it going to be followed by the doctor there? Is it going to be followed by our doctor? And then just waiting until they're going to be discharged from there to try to get them re-engaged in the clinic. What we found is a lot of the high utilization rates have mental health and substance use disorder as primary driver. And so having our psychiatric nurse has kind of brought in a different lens. And these are, a lot of these patients are, I think we touched on this earlier, are younger demographic. They're not that, they might have a lot of other medical comorbidities, but their highest need is a higher level of care that primary care is not really set up for. And what we were seeing is they're continually being sent to primary care when their needs are outside of what we can provide at primary care. So a lot of the focus now has been like, this person needs a higher level of care. How can we start that process sooner? And how can we get them to where they need to be sooner? So starting to ask the question sooner is like, is this person appropriate for primary care? Is it mental health? Is it SUDS? Is it both? Do they need inpatient, outpatient? Where is there an appropriate acute care team? And so we start to direct the patients over to, is it maybe CATC, LifeWorks, Cascadia. OTRC has several acute care teams, CODA. Some of the things we've learned is with this team approach, having different lenses. Our care team manager, she brings a relationship and medical, practical kind of lens. She knows the patients a little bit more intimately. She's been at the clinic a long time. Having our psychiatric nurse practitioner, she has a much better lens for behavioral and substance use disorders. And our CHIPS team, our CHIPS care, well, not CHIPS, our health resiliency specialist, her expertise and familiarity with the clinic, with the resources outside of the clinic, has facilitated a lot of things over the last year that wouldn't otherwise have been possible for us. One of the key things is, being on top of it ahead of time has allowed us to be a little bit more responsive, quite a bit more proactive. We know what's going on before they get there. We're able to get those records from the hospital, as soon as the note from the pharmacy, the pharmacist at Legacy, for instance, as soon as you guys do your thing, we start to pull it and get it to our pharmacist. The discharge summary goes directly into the chart. We get to know who the loyal patrons are of Legacy and Providence and all of that. We're watching them and have a better idea of what makes them tick. Despite all that, there's still gaps, right? And that's why we're all here. Even while we're outreaching actively, while we're trying to get them intakes at OTRC, they still get discharged on the weekend, or maybe not on the weekend, whatever. But that's one gap. Patients can refuse. Some of them are just not ready, and you're just trying to work with them wherever they're at. And yeah, they just don't show up. So you do all the work, you outreach, and they just don't show. Yeah.
How often do you huddle?
We huddle once a week on Fridays.
Okay.
But we're constantly working on those patients. throughout the week. Like I said, that's the grunt work.
Have you considered using a peer to help with using a peer, mental health peer, behavioral support, behavioral health peer to help connect with folks where they're at and accompany them, support them to get to appointments and things?
Well, yeah, yes, but that's where I was saying that, for instance, we're primary care, so we don't have case managers. And so that agreed, like...
But I guess I'm suggesting as a resource that might really help close that gap is using peers, not actually case managers, but peers.
Right, which they have access to... yeah, and so that's part of the work, is trying to get them hooked up with those peers. Trying to get them hooked up with, for instance, OTRC, where you have case managers, you have peer support specialists. Each acute care team has a social worker who has a caseload of maybe 50 patients, where our team by itself has 1,500 patients. And that's why I was saying identifying who these patients are that need that higher level of care and trying to get them engaged there quickly would be great. I mean, I you know, if you ask me one thing that we could do that would, if you look at San Francisco, they have one intake process for mental health, where each team at OTRC, you need to do a different referral for each one, which, I mean, it's just kind of stupid, but you know.
Well, I think there's been some success demonstrated in the past when you if you can get them hooked up with a peer before they're engaged with the PCP.
Yeah.
To help get them to the PCP and the mental health appointments. And we had a pilot project here a few years ago where we did that with a few really high-risk, high-utilizing clients, and we got them to 100% of their appointments while they were engaged with the program. All kinds of appointments, whether it was PCP, mental health, whatever. Having that peer to go get them, go with them, made a huge difference.
I agree, and CCC has that under the CCC umbrella. They have peer people, and one of our patients, I mean, you know, dear patient, he has in the hospital system, I think he has 5 different names. That was one of the main things that got him engaged, and we've been able to manage him is because he has that peer support, and he has that level of trust with him.
Carlo, you may have said it already, I may have missed it. Is Pioneer doing this high-risk huddle only?
That's why we're the only team doing it right now.
Is there others, Falcons, Bridges, the rest of them going to think about it?
Yes, and that's why, so based on what we're doing now, and why they kind of, when I took it over, they asked me, are there any things that you think we could do better, and can we start tracking this? And I'm actually, we're tracking it on an Excel sheet, which is redundant. But yeah, the idea is to eventually have the other teams do it. I think maybe scale down a little bit, but if you ask me, I think one of the main things is having the provider and the lens of the provider and the lens of the care team manager there.
You look at Old Town's charts from a HEDIS point of view. Are you documenting all of your huddle information? Because that's just rich with data of coordination. And
Yeah, so something I glazed over because I was nervous and just really tried to blow through this thing. So at the beginning of the week, if it's somebody that we're going to do a huddle for, I start a note in their chart, and then everything gets documented in there, which is why I said the spreadsheet seems kind of redundant. I would, the computer nerd in me would like to have everything, have a filter that just finds the title of the document. So I'm titling everything the same way so that we can track things, some kind of quantitative data from that, which I think is the plan. Yeah. Cool, thank you.
Guys, please give a warm Thank you to Carlo. Awesome. Thank you, Carlo.
Thanks.